Good morning. This is Agnes Fogo. I am a professor in the Department of Pathology, Microbiology, and Immunology at Vanderbilt, and delighted to introduce my colleague and collaborator, Dr. Christina Wyatt, who is Associate Professor of Medicine in the Division of Nephrology at Mount Sinai currently, and she's going to share exciting perspectives for our discussions and learning on the kidney and HIV implications for treatment and prevention.
Great. Well, it's a pleasure to be here. Thank you all for joining. And I would like to start just by reminding everybody here that kidney disease, and particularly advanced kidney disease and end-stage kidney disease in patients with HIV infection, comes from multiple causes. We often think just about HIV-associated kidney disease, and I will speak to that this morning. But patients also are at risk for acute kidney injury and subsequent CKD on that basis. Patients have increased risk for comorbid chronic kidney disease and also for treatment toxicity. And I'll touch briefly on each of these this morning. Just a couple of things that I think are important as background when considering the literature on kidney disease in patients with HIV. And those are two limitations of the studies. And these are really limitations of essentially each epidemiologic study that I will review today, and I think it's important just to keep this in the back of your mind. The first is that just as there are in other populations, there are limitations of the estimates that we use for glomerular filtration rate, or GFR, in patients with HIV, and there are some unique limitations in this population that I'll talk about in just a moment. And in addition, there's some limitations of study cohorts that are unique to HIV. So this is actually just a schematic of the renal tubule and discussing the clearance or the secretion of creatinine. And I'd like to just point out that there are a couple of drugs, including dolutegravir and rilpivirine, that have sort of a trimethoprim-like effect. So the drugs that have the strongest impact are the integrase inhibitor dolutegravir and the new pharmacoenhancer cobicistat. But a similar effect has also been seen with rilpivirine and with the older pharmacoenhancer, ritonavir, at least in vitro. So each of these agents can impact or interfere with the secretion of creatinine, which can cause an artifactual increase in serum creatinine, similar to what you would see with a drug like trimethoprim, or sort of with the classic agent cimetidine that causes this effect. And it seems that this is sort of a unique HIV-related or antiretroviral-related phenomenon. There are a few drugs used in oncology that have a similar effect. So this, I think, is important to keep in the back of your mind, particularly for studies that are coming out now, because dolutegravir and cobicistat are fairly new agents. So as new epidemiologic studies start to include patients who are taking these agents, I think it will be important to remember this impact. And certainly in clinical practice, if you're seeing these patients, it's important to remember. On average in the studies, the increase in serum creatinine was about 0.2 milligrams per deciliter. And so that could have, in some cases, a clinically relevant impact on the estimated GFR. So should we be using an alternative to creatinine in these patients? And one possibility would be cystatin C. Unfortunately, cystatin C also has some limitations in the setting of HIV infection. It is very strongly associated with mortality, and actually a stronger predictor of mortality than is creatinine-based GFR. But typically that's not what I'm trying to predict when I estimate a GFR. I'm usually trying to predict the GFR. And unfortunately, because it reflects both GFR and inflammation, it is a bit biased in the setting of HIV. Similar to studies have shown similar effect in inflammatory diseases like lupus and hepatitis C. So it tends to underestimate GFR in patients with HIV infection. With that said, in clinical practice, I do often use, or not often, but I do occasionally use cystatin C in a patient who has a marginal GFR, marginal estimated GFR, and is taking one of those drugs that I mentioned before. So one of these drugs like dolutegravir or cobicistat, and where I don't have previous results to really figure out what's going on, sometimes I will send to cystatin C and estimate a GFR based on that in order to determine whether this is just an impact on the serum creatinine. Because some people, although the average increase is 0.2, there are some outliers. So there are some individuals who will have a more significant rise in creatinine just from the tubular interference. So with that said, similar to many other populations, GFR estimates are limited, and it's important to remember that. Also, these studies, and almost all the studies that I will talk about today, are confined to secondary analyses of patient cohorts that were assembled for some other reason. So some of them are observational cohorts that were largely assembled to look at HIV and AIDS-related outcomes. And some of them were clinical trials that were also designed to look at AIDS and HIV-related outcomes. So none of these studies were really focused on kidney disease. And as a result, they're often lacking important data. Often your data on urine protein are lacking or are limited. There's never any history, any information about family history of chronic kidney disease. And there's often limited information about traditional risk factors such as diabetes and hypertension. So again, just to remember this when we talk about and when you look to the literature on kidney disease and HIV. So with that, I want to turn and just briefly talk about each of these contributors to advanced CKD and end-stage kidney disease in this population. First, acute kidney injury is more common in patients with HIV infection than in sort of similar age and otherwise matched HIV uninfected individuals. And it looks like, although there has been an improvement in overall survival in this population, that there continues to be an increase in the incidence of severe acute kidney injury. So recently, Girish Nadkarni looked at some data in a US sample. It's a representative sample of hospitalized patients called the National Inpatient Sample. And in there was actually an increased incidence of acute kidney injury that required renal replacement therapy. So again, this is a good example of a database that was limited. This database is an administrative database, and we didn't really trust the earlier stages of acute kidney injury. But once somebody requires renal replacement therapy, we've decided that was, those cases should be fairly clear cut. And actually, the incidence over time was increasing rather than decreasing. And this seems to be associated with increasing age and other sort of an increase in the prevalence of traditional risk factors for kidney disease in this population as the HIV population in the US is aging. Similar to what we know about acute kidney injury in the general population, acute kidney injury in patients with HIV is strongly associated with adverse outcomes, including mortality. What causes acute kidney injury in HIV? And I pointed out here, you see at the bottom that one of the references is from 2005, and that was probably the best study trying to look at etiology of acute kidney injury in patients with HIV. And in that study, they actually adjudicated each case in a prospective cohort of patients. This is one of the few studies that was designed to look at AKI. So it was a prospective cohort that was assembled and followed over a few years, and they looked at the incidence and risk factors for acute kidney injury. It's a great study, but as you can see, it's more than 10 years old. So these data are a bit outdated. They found a number of risk factors, really, which were quite similar to what we would see in the general population. Systemic infection was the strongest risk factor, and then some AIDS-related factors, such as lower CD4 and higher viral load. The data that I mentioned from the administrative database, the US National Inpatient Sample, also suggests that sepsis was strongly associated as a risk factor for dialysis requiring AKI, suggesting that, again, systemic infection, just like we see in the general population, sepsis is a strong predictor of AKI. And the other risk factors, as I mentioned, reflect really the aging of this population. So in the US, with prolonged survival on antiretroviral therapy, our population is getting older and fatter like the rest of us. And so there's more diabetes, hypertension, more underlying CKD, and also higher rates of liver disease, all of which were also associated with AKI. I'm going to sort of switch gears here and talk just briefly about HIV-associated kidney disease. And really sort of there are three main categories that people consider to be potentially etiologically linked to HIV infection itself. The classic disease of HIV-associated nephropathy, or HIVAN, which I'll talk about in a moment, some HIV-associated immune complex kidney diseases, and then certainly thrombotic microangiopathy. That last category, I won't really speak about any further because we see very rarely in the United States, but I do understand from our recent KDIGO meeting in Cameroon in March that our colleagues in sub-Saharan Africa are actually still seeing this much more commonly, particularly in South Africa, I believe, where the introduction of ART was much more recent. So HIV-associated nephropathy, or HIVAN, really is the classic kidney disease of HIV infection. It was first described back in the early 1980s, really very shortly after the first cases of AIDS were described. And these were patients who were largely either African American or the earlier cases were in Haitian immigrants. So these were all individuals who are of African descent, and we now understand that much of that genetic susceptibility is linked to polymorphisms in APOL1, those same risk alleles that are associated with FSGS in the general population as well. This is a disease that typically occurs in the setting of very advanced HIV or AIDS. So these are not patients typically who have early stage disease. And HIVAN is a collapsing form of FSGS with associated tubular interstitial changes, including inflammation and these sort of classic looking microcysts, which are shown here. Immune complex disease has been a little bit more complex to study over time. The causal relationship to HIV infection, the natural history, and the treatment remain less clear. And much of this is because people have really sort of lumped together a very heterogeneous spectrum of diseases. So under classically the term HIVIC, or HIV immune complex kidney disease, and this has been used often as sort of a wastebasket for diseases that are quite different from one another, and that may and very likely have different causal relationships to HIV, as well as different natural histories. And so it's not surprising that the studies have been a little bit less consistent in terms of showing that this is a disease that's clearly related to HIV infections. So I didn't mention this before, but HIV-associated nephropathy is a disease where we know based on animal models and epidemiologic data that this is a disease that is causally linked to HIV infection. In animal models, you have to have HIV gene expression in the kidney in order to get the disease. Unfortunately, in immune complex kidney disease, there's no animal model, and as I mentioned, epidemiologic studies have been limited by the really heterogeneous spectrum of disease. As a result, at this meeting that I mentioned in Cameroon in March, the renal pathology group really decided that it didn't make sense to continue to include all of those diseases, those disparate diseases, under the single classification of HIVIC, or HIV immune complex kidney disease, and strongly recommended doing away with that term. So hopefully we anticipate sometime early in the new year to see that publication in press, and at that time there's really a very clear outline, and Agnes was one of the co-chairs of that group, really identifying each individual histologic condition in the setting of HIV, so that we can really start to learn now about IgA nephropathy in the setting of HIV without muddling it together with MPGN in the setting of HIV, which may or may not be linked to HIV infection and respond to antiretroviral therapy in the same way. So that's all I'm going to say about kidney disease and its direct link to HIV infection. And I would like to turn and talk about what I see more of in clinic now, which is actually comorbid chronic kidney disease in this setting. So I just recently had someone take over my part of my clinical practice in the HIV clinic, and we were joking, she's writing a review article with me on antiretroviral toxicity, which is the last topic I'll talk about. And I said, you know, hopefully this review article is going to be really helpful for you in the clinic. She said, but all I see is diabetic nephropathy. And I think that's really in many ways true. Certainly in populations in the US and Western Europe, where patients have been exposed to antiretroviral therapy for a long time, they're living longer, HIV has become a chronic disease, and either HIV infection or prolonged ART exposure have been associated with increased risks of traditional risk factors like diabetes and hypertension. Certainly in the United States and worldwide, I would say HIV is a disease that disproportionately affects people who are of African descent. And there are also higher rates of hepatitis B and C virus infection, which have also been associated with CKD. So really, patients with HIV infection have an increased prevalence of traditional risk factors for CKD. And what we're seeing as a result of this is a lot of diabetic nephropathy, a lot of what may be either APOL1 related, sort of more traditional CKD, that, quote unquote, hypertensive attributed APOL1 disease. In addition to that, there's some evidence that there may be an additive effect of HIV infection and some of these comorbid risk factors on CKD progression. The strongest data are for diabetes, where there's some data. There are actually 2 studies from the VA population that really suggest that having both HIV and diabetes is associated with increased risk for CKD progression compared to having either of those diseases alone. And in an animal model of HIV transgene expression in the kidney, so where this is an animal model of HIVAN, on a genetic background that wouldn't typically get disease, if you give those mice diabetes, they now get pretty significant disease. So these are mice that generally wouldn't get diabetic nephropathy or HIVAN based on their genetic background, but if you give them both, then they do develop disease. So this does seem to be some additive effect of HIV and at least this one comorbid risk factor that could have very significant impact on our patient population. So I think that we're learning more about this in the animal model. It looks like it's probably an additive effect on inflammatory pathways that's driving disease progression. So I've mentioned this, and most of these studies that we've talked about so far have been done in patients who are antiretroviral experienced, who've been on ART for many years, or in patients who have advanced HIV disease. So we know less about the patients that we're seeing now who are starting HIV therapy at earlier stages of HIV infections. So the current guidelines, the US guidelines, the European guidelines, the WHO guidelines recommend starting antiretroviral therapy as soon as someone is diagnosed, at least in settings where that's financially feasible. And initially those guidelines were just based on sort of expert opinion and gut feeling. And then there were a number of studies, and I'll talk about the START study as one of them. Temprano was another study that also supported those guidelines. Essentially, the START study randomized over 4,600 patients who were antiretroviral naive, and they had CD4 counts above 500. So at that time, at the time the study was started, people weren't starting HIV therapy in patients with CD4 counts of 800 unless they had some other clinical indication. So essentially, patients were randomized to either start ART right away, immediate ART, or to defer ART until their CD4 was less than 350, or until they had one of those clinical reasons to start. And essentially, the START trial wanted to be a generalizable study. So one of the major limitations of many clinical trials is that you can't really apply it to your patient population. So on purpose, this study, attempted to have broad entry criteria. There was no exclusion based on GFR, which is rare for a clinical trial. If you think about most of the HIV trials used a creatinine clearance cutoff of at least 60, if not higher. So for START, the only kidney-related exclusion was if patients had been on dialysis. About a third of the population was of African descent, some enrolled in Africa and others in the United States and Europe. And about 20% of the population had hypertension. Diabetes was rare because they excluded patients who had a sort of life-threatening other disease. So about 4% of patients had diabetes. The START trial was actually terminated early because there was a clear benefit or clear evidence of benefit for immediate ART. So that was starting ART in people, whether their CD4 was 505 or 850, on the composite outcome, which was serious AIDS or non-AIDS event or death. And so the study was stopped early, and they continued to follow patients for the planned follow-up period. So what do we know about kidney disease in this population? So this is an opportunity now to look at CKD in patients that are much more like the population that we hope to be seeing going forward. So prevalent CKD was actually pretty rare. There were less than 1% of patients had an estimated GFR less than 60, and about 6% had proteinuria as based on a dipstick. So as I mentioned, these studies, if they have data on proteinuria, it's usually just dipstick proteinuria, not our ideal as nephrologists. But this 6% is actually higher than you would expect for age, because this was a cohort with a mean age of 37 years. So if you compare to something like Framingham, for example, this actually, is pretty similar, but that's an older cohort. So this probably suggests that there's probably more prevalent CKD even in these patients with very early HIV disease than there should be. And when we follow them over time, you see there's actually an early improvement in eGFR in the immediate ART arm. So this is a statistically significant difference at about 2 years. And in the paper that we published, this paper here, this ACRA paper, there's actually, the curves were truncated at 3 years because this is where we had really adequate data to draw a curve. Interestingly, and these are data that we're looking at now, when you follow the curves out beyond 3 years, they actually seem to both to converge and then cross, suggesting that prolonged exposure, longer exposure to antiretroviral therapy may actually have a negative impact on estimated GFR. And I'll turn to talk about potential reasons for that next. So again, there does seem to be some early impact of initiating ART even in early HIV that may reflect some impact either on HIV gene expression, such as in patients with HIV and with African descent or APOL1 risk alleles. One reason I suspect that is because the effect was mostly seen in individuals who were of self-reported Black race. So suggesting the benefit was mostly in people of African descent. So this could be sort of an early high band phenomenon that we're treating here. And I suspect that this, the decline in GFR that happens after 36 months may actually reflect prolonged exposure, cumulative toxicity from first-line ART. So just to sort of summarize this, we're seeing a changing spectrum of chronic kidney disease, a lot of diabetic nephropathy and arteriolnephrosclerosis, some of that immune complex disease that I mentioned. But we're also seeing a lot of non-collapsing FSGS. So in the new KDIGO recommendations for classifying histology and HIV, this will be just FSGS NOS, not otherwise specified in the setting of HIV. And we're actually seeing a lot of this as time goes on, and there are a lot of interesting questions about whether or not this is just APOL1 mediated disease in somebody who could have gotten it with or without HIV, or whether this is sort of partially treated HIV-associated nephropathy. And I think there'll be some interesting data on that in the years to come. And then finally, we're also seeing some evidence of drug toxicity. And that's really the last topic that I'd like to cover this morning or afternoon, depending on where you are in the world. So I've listed here the drugs that have been most closely linked to antiretroviral nephrotoxicity. And I've included both the brand and the generic name. The primary reason being that for tenofovir disoproxil fumarate, or TDF, many of us only see these drugs in fixed dose combinations. And I think it's important to know what's in these fixed dose combinations in order to know whether there's a potentially nephrotoxic drug included there. I'm going to speak primarily about TDF or tenofovir, but it is important to remember that some of the ritonavir boosted protease inhibitors have sort of followed in the footsteps of indinavir in terms of causing potential nephrotoxicity. Indinavir was one of the earlier HIV protease inhibitors that was approved, and it really fell out of use after a few years because of unacceptably high rates of GU and kidney toxicity, including kidney stones, crystalluria, and interstitial nephritis. And I do still occasionally see patients who have CKD that's likely related to prior indinavir use. And so it is still, I think a clinically relevant drug to remember. Some of the newer agents, including atazanavir and boosted lopinavir, also have been associated with kidney stones and potentially with occasional case reports of interstitial nephritis. And both of these drugs have also been associated, as has TDF and indinavir, with low GFR in epidemiologic studies, so suggesting that exposure to these drugs may increase the risk for chronic kidney disease. So I'm not going to speak much more about the protease inhibitors, but I do want everybody to be aware that if there's a patient who's got progressive CKD without traditional risk factors and really not much else to explain it, that I would tend to at least consider whether there were alternatives to a drug like atazanavir or lopinavir in those cases. So I'm going to speak mostly about tenofovir because this is a component of more than 80% of HIV regimens worldwide. When I talk about tenofovir, at least for this first part, I'm really talking about TDF, which is the prodrug that's been in use for the longest. Tenofovir itself has got very limited oral bioavailability, and so it has to be formulated as a prodrug, and TDF is the drug that we're most familiar with. But the drug, the tenofovir itself, is the nephrotoxic agent, and it's been associated with proximal tubular injury. Again, where there's loss of the proximal tubular brush border, you can see then in clinical manifestations, including both a rise in creatinine in some cases, but in many cases just isolated proximal tubular dysfunction. On electron microscopy, you can see evidence of really significant mitochondrial dysfunction, and although we don't know as much as we would like to about the pathogenesis of tenofovir nephrotoxicity, it's thought that it's likely related to mitochondrial damage, similar to what you see. Tenofovir is a nucleotide reverse transcriptase inhibitor. And if you may have seen cases of patients with lactic acidosis attributed to the nucleoside reverse transcriptase inhibitors, also a mitochondrial damage effect. So the thought is that most likely tenofovir is doing something to the mitochondria in proximal tubular cells that's damaging. What happens to patients in this phenomenon? These are data from a small case control study of patients that had really full-blown Fanconi syndrome from tenofovir, and it looks like probably risk factors are similar to the risk factors for other toxicity, including the use of ritonavir-boosted protease inhibitors and lower baseline creatinine clearance. Interestingly, both of these factors are factors that increase exposure to tenofovir. So what happens when you take TDF, the prodrug, is that most of it is absorbed as tenofovir. So there become then very high levels of tenofovir in blood, in plasma. And these levels are increased in the setting of ritonavir-boosted PIs, largely actually because of increased bioavailability, increased absorption in the GI tract in this setting. Possibly some people have also suggested some decreased clearance at the kidney, but I think the main effect is from increased absorption. And also you can imagine this is a drug that's cleared partly by GFR and partly by tubular secretion. So if you have a lower baseline kidney function, then it's not surprising that you'd be exposed to higher levels of the drug. If you stop the drug in time, the tubular dysfunction, not surprisingly, recovers quite quickly. We know that tubules have a nice ability to regenerate. But some of these patients will continue to have proteinuria, and many of them, in patients who already have established GFR decline, will not recover their kidney function. So as with other causes of acute kidney injury, this may not be a fully reversible phenomenon. Even in the absence of, so Fanconi syndrome, this proximal tubular injury, is sort of the classic phenomenon, the classic manifestation of tenofovir toxicity. But we also see some cases of just GFR decline without evidence of proximal tubular injury. There were very early data and early meta-analysis that looked at some of the pre-marketing clinical trials of TDF as well as observational studies, did show a small but statistically significant greater decrease in creatinine clearance compared to non-TDF regimens. And observational studies have suggested an association with GFR less than 60. So I mentioned these studies have also found that same association with the boosted protease inhibitors used with or without TDF. Interestingly, these analyses have been a little bit complicated because it looks like providers are discontinuing these drugs as the GFR approaches 70. Not surprisingly, they're recognizing that something might be going on and worrying that the drug could be contributing. Finally, I'll just mention that in clinical practice, what we probably see the most often is actually proteinuria in patients with tenofovir on TDF. Classically, you would think this is going to be sort of proximal tubular proteinuria, low molecular weight proteins that are not being reabsorbed. There is also some albuminuria associated with TDF use. Interestingly, the clinical relevance is unknown. So we all know that proteinuria and albuminuria are predictors of bad outcomes, but we don't know whether these predict GFR decline or cardiovascular disease in the setting of drug-induced proteinuria. So I think this is a question that we don't really know the answer to. So there is a newer prodrug. So I've been talking about TDF really up to this point. And because of the known kidney and also bone toxicity, so TDF is also associated with greater declines in bone density, tubular injury. The manufacturer has gone forward and developed a new prodrug, tenofovir alafenamide or TAF, that it achieves higher intracellular levels. So for example, higher levels of tenofovir inside CD4 cells, target cells, and similar rates of antiviral effect, but with much lower plasma concentrations of tenofovir, which are thought to be the driving factor for kidney and bone toxicity. So this drug was expected to have lower kidney and bone toxicity, and in at least the early trials, it suggests that that's going to be the case. These are data from a phase 2 study, and the similar results have been seen in the phase 3 studies, but they haven't published similarly beautiful curves. Essentially, this is comparing patients who were on Stribild, which is emtricitabine, cobicistat, and TDF versus the same thing with this is elvitegravir, cobicistat, and emtricitabine and TDF versus the same 3 drugs with TAF, or the tenofovir alafenamide. And you can see the cobicistat effect here. So these are ART naive patients. They're started on drug, and all of them have a decline in their estimated creatinine clearance. That is the cobicistat effect on tubular secretion of creatinine. And then there's a difference in the curves that favors TAF. So this is the TAF line here, and you can see that the creatinine clearance remains higher over time. This is actually probably true. It seems to be true out to 96 weeks in the longer term study. So suggesting that TAF has less effect on GFR decline. It also seems to have less effect on proteinuria. So this is urine protein creatinine ratio and urine albumin creatinine ratio. This is the TDF containing regimen. This is the TAF containing regimen, again in ART naive individuals. So suggesting that there's a greater increase in both proteinuria and albuminuria to a lesser extent in patients who were started on TDF versus TAF. So this is all, reassuring. To a certain extent, the 96 and 144 week follow-up in the clinical trials has started to show some small differences in outcomes that we really care about, like clinically significant declines in GFR, or the prevalent the incidence of real proximal tubular injury, suggesting that these sort of biomarker differences are probably going to translate into real clinically relevant differences with prolonged use. So hopefully TAF will be safer, although again, the data on hard outcomes are still quite limited. Another advantage of TAF is that it's approved down to a creatinine clearance of 50. So TDF is only approved down to a creatinine clearance of 50. So you can use a TAF down to a creatinine clearance of greater than 30, I apologize. So this allows for the first fixed dose combinations in patients with creatinine clearance between 30 and 50. In the past, they didn't really have any good options. Unfortunately, it's important to remember that now the plasma tenofovir concentration is going to start to go up, because even though the concentrations, the drug amount is actually about 10-fold less than with TDF, eventually you can get plasma tenofovir concentrations that look very similar to those in somebody taking TDF if the GFR is low enough. And there has been at least one case of AKI published in the literature that was attributed to TAF. And this was a patient who started out with marginal GFR and had multiple risk factors for AKI that probably first triggered AKI with a further decline in GFR and a rise in tenofovir levels to the point where the tenofovir likely, became a sort of a second hit in that situation. So I want to just turn and briefly talk about tenofovir for HIV prevention, because this is something that I think in clinical practice many of us are starting to see more of. TDF, emtricitabine, or Truvada, is currently FDA approved and also approved in the EU and elsewhere worldwide for pre-exposure prophylaxis for HIV prevention in patients who are at high risk for HIV infection. Obviously, these are healthy individuals, so I have an even lower tolerance for adverse effects than I would in people who are trying to treat a disease like HIV. And the good news is that there was no overt kidney injury in the randomized controlled trials of TDF FTC for HIV prevention. But it's important, like most clinical trials, to remember these people are healthier than the general population, and these were all healthy adults who didn't have really any CKD risk factors. They had very close monitoring of creatinine and urinalysis in some cases, and drug was stopped with a fairly low threshold. And also there was very poor adherence in most of the trials. So some of the PrEP trials didn't even show a benefit for tenofovir FTC because people didn't take it. So just like anything else, you have to take it for it to work, but you also have to take it for it to cause side effects. So in meta-analysis, we can see that there is actually a higher incidence of sort of creatinine events. So these are, increases in creatinine of, more than 25%, for example, compared to placebo. So it does seem to have a similar effect even in the randomized trials as TDF did in HIV-positive people. In 3 randomized controlled trials, there have been secondary analyses that also confirm a similar effect on GFR decline. So a very small but significantly greater GFR decline in patients who are randomized to active tenofovir-based PrEP compared to placebo. 2 of those studies have had small sub-studies that looked at differences in proximal tubulopathy and didn't really see any statistically significant difference. Although I will note that in the study that I was involved with in the Partners PrEP trial, we did see one case of, pretty flaming Fanconi syndrome with, multiple markers of proximal tubular dysfunction. This was a patient whose drug was stopped during study because of a creatinine event. Restarted and then restopped again, and finally not continued because of creatinine events. And then in secondary analyses, when we looked at bank specimens, we were able to identify, significant evidence of proximal tubular dysfunction as well. So it can happen in HIV uninfected individuals as well. And I'll just add, so you might think, why don't we just switch to TAF? And TAF is actually being studied for PrEP. But it's not currently approved for this indication. And there's some suggestions that it might not work because the levels, depending on why PrEP works. If HIV prevention is working because of high plasma concentrations, for example, of tenofovir, then it shouldn't work. If it's working because of high intracellular concentrations in CD4 cells, then it should work. But if you need mucosal cells to have high levels, then TAF may not work. So we're not sure. And again, we're also still not 100% sure that TAF is going to have a significant impact on clinical safety over time, but that's something to keep an eye on. Let's see. So in summary, I think the important things to take home from this are that these patients continue to be at increased risk for kidney disease related to both HIV factors and traditional CKD risk factors. Tenofovir, in particular TDF, and the protease inhibitor-based regimens may increase this risk. And it's also important to remember in clinical practice that some of these agents may interfere with creatinine, and that the lessons that we've learned, particularly about TDF, may extend to HIV prevention as well. So I'll stop there and see if folks have any questions. Thanks for your attention.
So we have some questions here. A comment first, talking about the early ARV START study with crossover occurs, wondering about whether there could be an emergence of immune complex disease, or what we previously called HIVIC. Have you observed that, Christina, in the early ARV START study?
Sure. I mean, that's a good question. The START trial, we don't have a whole lot of data on, the study wasn't designed to look at kidney disease. So as with any trial, they are collecting and adjudicating data. If somebody were to start on dialysis, for example, that would be an endpoint in the trial. That hasn't happened yet. At the time that we had our data, there were like 4 or 5 hard clinical outcomes that were not different between the 2 arms. I'm not sure that we'll be able to look at specific causes of kidney disease, although we do have banked plasma and urine. So we will be able to look at things like proteinuria, for example, to see whether it is associated with the proteinuric kidney disease. I think this also, though, raises the other question of whether ART is driving HIVIC, which is a sort of controversial concept that has appeared in the literature. What I will say is that I don't necessarily think that ART is a cause of immune complex kidney disease in patients with HIV, although I think there are probably some experts in the field who think that it might be. I think that the reason that what the epidemiologic data have suggested is that HIVIC does tend, unlike HIVAN almost always occurs in individuals who are not ART exposed. Either they have never started and have advanced HIV disease and just got diagnosed late. They didn't start because they didn't want to, or they're not adherent to their therapy. In contrast, immune complex disease, whatever HIVIC means, this wastebasket of diseases, can occur in patients who are very ART experienced. And so some people have taken that to mean that ART is causing it. My personal opinion, and again, not proven, but my personal opinion is that this likely just reflects the fact that it may not, or not all causes of it are related to direct HIV sort of viral load, but that there may be something related to prolonged exposure to the systemic inflammation that still happens even under virologic suppression, even on ART, but that that prolonged exposure may result in HIVIC. So that's a long way of saying I don't think that ART is causing it. So I'm not sure that the crossover necessarily means that people have been exposed to ART longer and are now developing HIVIC, but it could be that people have been exposed to HIV for longer and are no longer at risk for HIVAN because they've been treated, and so now the disease that they are, sort of by competing risk sort of set up, are now exposed to HIVIC. So I think certainly an interesting question. I'm not sure we'll be able to answer it and start, but it's certainly something interesting for us to consider.
Yeah, and I would just add as a kidney pathologist that differentiation of a cause of proteinuria in these patients would require a kidney biopsy. So related to the effects of these drugs in the kidney, the next question wonders about TDF causing mitochondrial disease in the proximal tubule. Why does it not, or does it cause disease or injury in other metabolically active cells? Do you want to tackle that one, Christina, or Hunt?
Sure. I mean, that's a good question. And I mean, I don't, if you mean other metabolically active cells in the kidney, then probably to a lesser extent it does, but it is partially, so tenofovir is cleared, and this is tenofovir regardless of whether you took TDF or TAF. So you took TDF or you took TAF, you get tenofovir in plasma, and that's what's cleared by the kidney. It is cleared mostly by glomerular filtration, but partly by proximal tubular secretion. So there's just more tenofovir in proximal tubular cells than in most other kidney cell types. It doesn't appear to have the same effect on mitochondrial damage in other cell types outside the kidney as other nucleoside reverse transcriptase inhibitors do, because the risk of lactic acidosis with tenofovir, TDF or TAF, is much lower than with some of the other NRTIs, like some of the older ones like DDI, for example, that had sort of unacceptably high rates of lactic acidosis. So it seems to be more of a proximal tubule targeted mitochondrial toxicity, presumably because both those are cells that are more susceptible to mitochondrial depletion, and also because there's more tenofovir there.
Yeah, and I think some of the evidence also indicates that organic anion transporters cause concentration of tenofovir and also cidofovir in the proximal tubules, and they would be particularly expressed in the proximal tubule. So we have a molecular reason also to understand why the proximal tubules are hit so hard by tenofovir. The next question relates to a comment from somebody in Kenya saying, many patients in my country, in Kenya, present at late stages of HIV, often with renal dysfunction. They are acutely unwell and septic. Renal dysfunction is worsened by concomitant medications, but then they recover renal function. And the question for you, Christina, is, would you consider using TDF as a first line in this patient population in Kenya, presenting with late-stage HIV, renal dysfunction, acutely unwell, septic?
Sure. So, I mean, that's a tough question. And I think, in a resource-rich setting, I would say I probably wouldn't. The reason being that, as these people get better, if you've started them on dose-reduced TDF and they get better, unless they're being followed incredibly closely, you may actually miss a window to appropriately increase the dose. So that I think there is some risk of undertreating HIV in that setting. If you don't have other good, safe alternatives, I mean, TDF is a very effective antiviral drug. It's otherwise very well tolerated. So I think that it's not an unreasonable thing to consider at appropriate dosing. Obviously, you have to dose reduce it, and if somebody's got AKI because they're septic, it becomes a little tough to know exactly what you're doing. Obviously, we all know GFR is a problem in that setting. But I don't think it's necessarily excluded just because we know it's nephrotoxic. If you dose it appropriately and you really think that the AKI is related to their HIV infection, then I think it's not an unreasonable choice, particularly in settings where there are limited good alternatives.
So just for me to follow up on that then, if you have a patient who has HIV driving severe kidney disease and you treat with a drug that then causes mitochondrial toxicity in the proximal tubule, what is your experience with recovery of tenofovir-induced nephrotoxicity? Clearly, some of the patients have chronic injury, but have you seen patients who recover from tenofovir nephrotoxicity? What is your experience with that?
Yeah, I mean, my guess is that, for example, that TAF case that I presented before, where it's essentially the patient developed AKI probably from another cause, and then the TAF, the tenofovir levels get high, they get AKI. I think if patients develop acute AKI, usually in some other setting, they get sepsis and they're on TDF, they get high dose NSAIDs for some sports injury and they're on TDF. I think those patients probably have a pretty good chance of recovery. So I think if somebody's exposed in this setting like this patient, these examples in Kenya, if somebody is exposed to tenofovir and the risks of tenofovir for a short period of time, and then their kidney function otherwise has a chance, whatever the inflammatory or HIV-related component is, has a chance to improve, I think those patients do have a better chance of recovery. The patients who have sort of an insidious course, the ones where I look back and their phosphorus has been low for 2 years and they've had a little proteinuria for 2 years, I think those patients are much less likely to recover.
So, of course, I'm not in the difficult situation that you are of titrating these drugs. If somebody has proven tenofovir-induced renal toxicity, do you switch them to another drug or decrease the dose, or what other adjustments would you make to balance the need to treat the HIV infection and mitigate the injury caused by the drug?
Sure. So I think if somebody has proven, if somebody shows up with proximal tubular injury on TDF and there wasn't a clear trigger, I would say just like you would say for a DVT, if somebody has a DVT in the post-operative setting, I'm not necessarily going to put them on lifelong anticoagulation. If somebody has TDF in the setting of TDF toxicity in the setting of sepsis, I'm not necessarily going to say that that person can't be rechallenged. But if somebody just in the regular course of life taking the appropriate dose of tenofovir winds up with AKI or proximal tubular dysfunction, I probably would not rechallenge that patient. And ideally, I would try not to rechallenge that patient with TAF either if I didn't have to. Because there's some studies that have suggested genetic susceptibility to tenofovir toxicity, and whether that genetic susceptibility, most of those have been in proximal tubular transporters that should have the same effect with TAF and TDF. So, ideally I would not rechallenge those patients. If you're in a setting where the only alternative is abacavir and your patients had a hypersensitivity reaction to abacavir, or they are known to be HLA-B5701 positive and are at high risk for abacavir hypersensitivity, then maybe I would try it with dose reduction. But I'd say in cases where I'm sure that the tenofovir caused the kidney injury and there's not another good explanation, I would try not to rechallenge.
And your answer already addressed the next question for one of our participants, wondering if there were pharmacogenetics for TDF to predict whether there was toxicity and resulting AKI. And I think you've alluded that there are some suggestions. Those are all the questions we have posted at this time. So I think that we have to thank Christina very much and instruct all of the participants who may have additional questions to send to the ISN website as Piero indicated. And I thank Christina very much and the participants.
Thanks, everyone.